On Wednesday, July 9th, the Department of Justice announced that it sent out 20 subpoenas to doctors and clinics that were involved in, quote, performing transgender medical procedures on children. They stated these subpoenas were to investigate for healthcare fraud, false statements, and more. It's not clear exactly what is included, but it sounds like patient info is included in the subpoenas. Usually when there's a question of fraud, they need full patient information, name, everything. On top of that, the Department of Justice Chief of Staff announced at a Federal Trade Commission event that they also sent out subpoenas to major manufacturers of drugs that are used in trans-related medical interventions. Now, you might think this has nothing to do with me. I don't care. But I'm going to tell you in this podcast why you should care. Whether you're a provider, whether you're a patient, it doesn't matter if you have anyone in your life that is requiring gender affirming care. I'm going to explain how this may affect you. So the first thing that comes to mind is any time that there are subpoenas of medical information asking for patient charts by the government, especially when it's around an identity, it breaks the patient-provider trust. When patients know that their information can be sent somewhere else, that other people could look at their information for any reason, it affects trust. Medicine requires that we have a certain level of trust with our patients, that they share some of the most intimate details of their lives so we can best treat them. We need to know what medications they are on, what risk factors they have, so that we can provide the best care. It affects our ability to deliver care. And if patients don't trust us, they are not going to share all of the information. If they think somebody else might be able to legally request this information and take it, it's going to affect our relationship and our ability to provide the best care for patients. Now, we know as a society, in this society, that there is an agreement that if at any point a patient states that they are going to harm themselves or others, that that is one time when confidentiality can be broken. Now, here's the thing about that. That is typically stated. It is mentioned multiple times. It has been that way for a long time. And so that is more commonly known. Now, some people might say, hey, but this is harm to others. So this falls under that category. But let's be honest with each other. I understand that some people may believe that, but let's be honest that that is bending what is initially intended by that statement. The statement is usually because somebody says they are going to kill somebody or they are going to seriously injure somebody. Let's be honest. Yes, we can start making things gray of what's harm, but I don't think we want to do that. It's not typically used in that gray sort of way. Let's admit that just because some people think that gender affirming care is harm does not make it so, especially when we have multiple medical associations that support the use of medical gender affirming care for some patients. Let's be honest that there are peer-reviewed medical research that supports the use of gender-affirming care for some patients. Even if you disagree with it, there is support for the care by institutions, by organizations, by peer-reviewed research papers. And so I don't think we want to stretch that definition in those ways. Anytime a law or something is used in a novel way, even when it's consistent and aligns with my own personal values, I always pause for a second. When it's used in a way that it hasn't been used before, I always pause for a second to think, how else could this be used? I might be excited it's used in this way because it aligns with my values or my beliefs, but how could it be used by somebody else that may not be in alignment with it? And I want you to think about that. Even if you don't believe in gender affirming care, stretching something that has medical evidence, that has medical support by multiple institutions, And you may have all your reasons why you think, I don't believe that. I don't believe the research. I don't believe the institutions. That's fine. It doesn't change the fact that that does exist. We can agree it exists. Whether you agree with it or not, it does exist. So what happens when another leader is in charge and doesn't agree with something? What if a leader thinks that anyone that vaccinated their child is a form of child abuse, and they want a list of every parent that's ever vaccinated their children? Let's talk about more controversial things. Some people don't think you should treat kids for ADHD, or they think there's an overtreatment of ADHD medically. What if the government said, I want all the records of every patient that's ever had ADHD treatment? How would you feel about your child, your loved ones, information being handed over to the government for being treated for ADHD just because the leader in charge questions the overuse of it? How would you feel if you knew that the leader in charge was one of the people that doesn't believe you should be treating so many kids for ADHD and wanted the information because they think maybe it's just poor parenting? Or what if they want anyone that's had any treatment for obesity, childhood obesity? They want a list of all those patients because they think there are better ways to handle it. They think that maybe the parenting's child abuse, the parents should have been able to do something. I mean, there's so many things where there are individuals out there that think parents and guardians could do more to change the reality for their children. How would you feel if your kids' records are on the line? How would you feel if your records, for whatever reason, were asked to be collected by an entity outside of healthcare for other reasons? We'd be very, very careful and selective of when we hand over medical records. Yes, it's clear in the law that there are certain reasons, but we have to be very careful. Sensitive information. And even if these subpoenas do not affect you or anyone you love, it gets in the psyche of everyone in the community that that's a possibility. It changes the relationship for that reason. Patient-provider relationship. Knowing that, this doesn't affect me. But knowing that somebody can ask for the medical records for legal reasons and stretch those reasons. All of a sudden, that relationship doesn't seem so protected. The second reason you should care is it's created to create fear in providers. And those providers that provide gender-affirming care provide other care for other patients. They are endocrinologists that treat all endocrinologic disorders for kids, including diabetes. They are adolescent pediatricians who specialize in adolescents. They are pediatricians. They are family medicine physicians. Putting fear in those physicians may decrease the number of physicians you see in those areas, especially endocrinology. Maybe it doesn't stop them from practicing, and the goal is to stop them from doing gender-affirming care. But here's the thing I know from a medical perspective. When there is a fear of providers of providing a certain care, there is a fear of providing any care, might not be gender-affirming care, but that could be misconceived, that could be questioned to be gender-affirming care. So one thing we've talked about before that you've heard in many of the arguments is GnRH agonists are used for precocious puberty. And one of the reasons they're used for precocious puberty is just imagine a 6-year-old girl developing breasts, 7-year-old boy developing a mustache. There are psychological consequences for going through puberty. They're going to be shorter. There are constitutional consequences as well. And you might say, no, but it'll be clear. You've got the records. We know what they were assigned at birth. It's not that easy. Sometimes people are looking, and we've seen this in government, when they're looking for prescription records, for providers that prescribe more, that might be the ones that see more often precocious puberty and might be prescribing it more. It just calls anyone to call into question, like, oh, that provider gave that patient GnRH. Yes, they're 6 or 7 or 8 years old. And yes, that might be the age range for treating precocious puberty, but that child's kind of gender nonconforming in their presentation. Are they just saying that and starting it early so it looks like precocious puberty and they might do it for a little bit longer, because the kid's actually gender dysphoric? This might sound insane to you, but it's not insane. Physicians get questioned all the time, and especially anything that looks similar, even though, yes, the information might be there. Hopefully, this patient didn't come from somewhere else. Hopefully, if they did, they have their medical records. What if they don't? But again, even if you have all the medical records, it just requires one person to question for an investigation to begin. Investigation begins, physician may have to stop practicing until that investigation ends. And even if they know that investigation is going to end up just fine, you can't undo public opinion. You can't undo what is put out there. Providers don't want to deal with that. And so they're going to be much more cautious. And I'm not saying everyone, there will still be people providing this care, but it's going to be with greater hesitation. Many less patients are going to get that care because of the fear of being accused of providing gender-affirming care. We will see this with hormones as well, which we've talked about, used for delayed puberty, used at a young age for micropenis. That is a reason. If infant is born with a penis less than 3 inches erect, that's a micropenis. Testosterone is a treatment. And I say, but that's in babies. Sometimes families don't know what normal is, and I have spoken to families that haven't gotten the diagnosis for their kids until a little bit older in childhood. Testosterone is a treatment. The standard of care is treating them with testosterone. What if that option's not available? Providers are going to be afraid to provide the care that can be seen elsewhere. And I guess this resonates for me as an OBGYN because the procedure, the analogy for me in the world I used to practice in, is that the procedure for an abortion is the exact same procedure that you do when somebody has an incomplete miscarriage. Miscarriage, completely different, but there's still tissue that needs to be evacuated. As abortion laws changed and became stricter and stricter, and more regulations put on, and now gone in some places, but even before Roe versus Wade was overturned, providers were not giving patients who had an incomplete miscarriage the option for surgical intervention because they did not want to be questioned of whether or not it was an actual abortion or not. Now you might say, but they should be able to prove it. There's no heartbeat. Yes, absolutely. But many people within the OR, within the healthcare system who are not physicians have to rely on the physician to interpret that. And even though you could have films, the ultrasound, etc., the minute they get investigated, everything's put on pause. Their name is dragged through the dirt, even if they're acquitted, even if they didn't do anything wrong. And for that reason, we saw providers not offering patients. The typical standard of care is offering to watch and wait as long as there's no signs of infection or surgical intervention. And because, as we saw abortion laws get stricter and stricter in those areas, providers were not giving that option to patients anymore. It was watch and wait only. And so you might think, yeah, but you can prove all these other things are different diagnoses. I don't disagree with you. But if you're called into question at all, it will affect you. Even though at the end of the day, you will be shown that you were doing what you said you were doing, the jury on public opinion is already done. The third reason you should care, even if you don't have a loved one that receives gender-affirming care, is the subpoena to the manufacturers. People use, of all ages, GnRH agonists, estrogen and testosterone for a multitude of reasons. And if those manufacturing are getting scared to provide it, everyone that gets those medications are going to be affected. We've talked about for GnRH agonists, precocious puberty, but we also use them for heavy menstruation, big uteruses with fibroids, heavy periods. It's also used in things like prostate cancer. Estrogen, not only delayed puberty, but something like Turner syndrome or anywhere else where a child has ovarian insufficiency. As they are developing, at the time someone might get it, as they're developing, you might use estrogen for ovarian insufficiency. I think about all the intersex patients, not everyone who's intersex, but there are some intersex conditions that require estrogen or testosterone. But beyond those individuals, when it comes to testosterone, same thing, delayed puberty, hypogonadism, micropenis, which I've already talked about and mentioned. But I even heard an OBGYN tell a story that she sometimes gives her postmenopausal patients testosterone. Female patients, testosterone, small doses, but that they get questioned at the pharmacy of whether they're transitioning, even though the doses are way different. Just because it's testosterone and it's not FDA approved, it doesn't matter. But this physician mentioned that they changed their practice. It affected their practice when they wanted to prescribe their patients testosterone because of the questioning of it. And this is what I mean when we start politicizing a standard of care, a standard of healthcare, it starts affecting more patients than what it is originally targeting. So that is how it may affect those individuals who don't have someone in their life that they love that have gender-affirming care. But I want to take just a second to talk about what about those families that do have children that receive medical gender-affirming care, that do medically qualify for that standard of care. There's concern, maybe panic even for some. There's concern that their providers will disappear and they will not be able to provide their child with the standard of care. They're worried about their child's name going on a list that's going to be somewhere in the government. What are they going to do with that list? What will that mean for their child? They're concerned that it will be used against them to investigate them for child abuse. If you're a provider, a healthcare provider, even if you don't provide gender-affirming care, it is important to know this about your patients and their families, that this might be some of the concerns on their mind. It is important, if you're a friend, that you're aware of what's going on. And I think just as a human being, to understand, whether you agree or not, how difficult this must be, how scary it must be to love your child and believe and choose that you are doing the best thing for them that has support, and that in the end it might put them in danger in one way or another. I wish that we could be humans about this. We don't have to agree, but we have to acknowledge. I can acknowledge that there's a CAS report, but I also acknowledge that CAS report has some flaws. Just like I can look at any other research paper and tell you it has flaws. And I also can tell you that the CAS report is often misinterpreted too. And I wish we could have more conversations about that. I'll be honest with you, I didn't expect to do this podcast. I'm ready for an end of season, a break, to be all in with my family this summer. So this may be the last you hear of me until the fall. However, as things come up, I might pop back in from time to time. But once September rolls around, I'll be back weekly to talk with you. Until then, try to be human to each other. Try to listen to each other. A lot of people are hurting right now. And even if you disagree with gender-affirming care, you might be hurting right now for other reasons. But let's find a way of stop hurting each other. Have a great summer.